Today I'm going to talk on preterm birth, the great challenge for Bharat. Why am I talking this? It's a big national problem for Bharat. Highest number of preterm births are born in India, and they are contributing to 50% of the neonatal mortality. It's a critical issue, and it requires awareness, public awareness, and awareness among gynecologists and nurses. Preterm birth, as you know, is a delivery before 37 completed weeks of pregnancy. It is not just a statistics. It's a leading cause of neonatal mortality in India, 45 to 50%, with over 3.5 million babies are born preterm annually. Bharat bears the highest burden globally. Coming to the problem of prematurity. As you know, highest global burden. India ranks first and accounts for 25% of the global preterm births. Is a leading cause of under 5 mortality, surpassing infectious diseases. It is economic catastrophe. Long-term costs of managing prematurity-related disabilities like cerebral palsy, blindness, and learning deficits impose a catastrophic financial burden on families and the healthcare system. Disparity in survival. Unmute kar lijiye. Preterm born in rural India has a significantly lower chance of survival compared to one in the urban tertiary care center. It highlights the equity gap in Bharat. There's a high prevalence of infections in mothers of asymptomatic bacteriuria, bacterial vaginosis, and even dental problems like periodontal diseases. These are stimulators of prostaglandins and cytokinin release, triggering premature labor. There are rampant nutritional diseases. Our country has 52% of anemia in pregnancy. Quite a significant number have low BMI, and there's a rampant micronutrient deficiency, especially of vitamin D and vitamin B12, and these are the two vitamin deficiencies which are creating havoc these days. They compromise placental health and the fetal growth, increasing preterm risk. If there's a shorter inter-pregnancy interval of less than 6 months, it is a significant modifiable risk factor for prematurity. Whenever there's a maternal genital tract anomaly, short cervix, less than 25 millimeter on transvaginal scan in mid-trimester is one of the strongest predictor of spontaneous preterm births. And this is what every gynecologist must learn, that along with anomaly scan, they should get cervical length also estimated at the same time for short cervix, and if it is less than 25 millimeter, vaginal micronized progesterone can work wonders. Whenever there's uterine distension like multiple gestation, twins, triplets, they are major iatrogenic natural risk factors. Maternal comorbidities like hypothyroidism, chronic hypertension, preeclamptic toxemia, unmanaged diabetes are all significant contributors. Placenta previa, placental abruptions are direct causes of preterm deliveries. Whenever a woman has stress problems, which 50% and more have it, and whenever she has a physical overload, strenuous physical activity, these are also independent risk factors for preterm birth. Adolescent pregnancy or pregnancy at advanced age, both extremes of reproductive age carry higher risk of preterm birth. And whenever there's a previous preterm birth, it is the most significant risk factor for recurrence of preterm birth. Now coming to the fetal problems, whenever there is intrauterine growth retardation, compromised fetus and a placenta indicated preterm delivery will be done by the gynecologist. Whenever there is a fetal anomalies predisposed to polyhydramnios, at the same time they can cause placental insufficiency. Both can lead to preterm birth. Iatrogenic preterm births from ART. Now, with increasing IVF pregnancies, there are multiple gestations are happening left and right. Unregulated use of ovulation inducers also is very common among gynecologists and people who are not gynecologists, self-styled gynecologists. And it is often overlooked, and which is the cause of multiple pregnancies and subsequent preterm birth in India. Now, consequences and complications are immediate neonatal morbidities, respiratory disease syndrome, intravascular hemorrhage in the baby, necrotizing enterocolitis, patent ductus arteriosus, and severe infections. These are the main causes of neonatal morbidities and death. Long-term neurodevelopment sequelae, we all know about it: cerebral palsy, intellectual disability, blindness, which is called retinopathy of preterms, deafness, learning and behavior problems are big problems in the society today, draining away a lot of economic resources of the country. Now coming to the solutions, which are evidence-based preventing strategies. Preconception care and optimization is most crucial. We must give them honest antenatal care. Screen and treat anemia. Hemoglobin of 12 should be aimed at the time of delivery. This will improve the IQ of the child. Hypothyroidism is very common, 1 in 5. It should be diagnosed and treated. Sexually transmitted infections and optimize chronic conditions before conception. Nutritional supplementation, I just now said, treat anemia, aim hemoglobin of 12 at delivery. There's a growing role of vitamin D and B12, and this should be picked up to prevent preterm risk in deficient populations. Adequate birth spacing should be there. At least 2 years gap should be there between the two births. Smoking and tobacco, big no. They are non-negotiable counseling points. Oral health of Indians is bad. Encourage dental checkups and treatment of periodontal diseases before and during pregnancy. Universal cervical and screening must be done. This is the secondary prevention, and all women at risk can be picked up. Advocate for mid-trimester transvaginal scan along with anomaly scan. It is a cost-effective strategy to identify at-risk asymptomatic women. Now coming to the progesterone supplementation, which is secondary prevention. Vaginal progesterone, whenever you find there is a short cervix of less than 25, if you give vaginal progesterone 200 milligrams twice a day, it can reduce preterm birth by 45%. As far as intramuscular 70 hydroxy progesterone caproate, 17 alpha hydroxy progesterone caproate, which is very popular among gynecologists, 250 milligrams weekly to be given from 16 to 20 weeks onwards till 36 weeks. It is effective whenever there's a history of spontaneous preterm birth in the past. Now, cerclage. Cervical cerclage remains a gold standard for women with a history of cervical incompetence and short cervix with prior preterm birth history. A pessary which is not used in India, it is Arabian pessary. It's a silicone device placed around the cervix, in short cervix, and in twin pregnancy. It has got mixed results. Some reports say it is effective, some reports say it is not so very effective. Coming to the specific conditions, screening and treatment of infections. Like if there is a universal screening should take place for asymptomatic bacteria, and the timely treatment should also be given. for symptomatic UTIs and vaginal infection of bacterial vaginosis, etc. Multiple pregnancy. This can be prevented. The West has done it by single embryo transfer during the IVF cycles. They cannot afford to have missed the job. Bharat should also strictly follow the same. Specialized antenatal care with close monitoring for growth, cervical length, and preeclampsia is also very, very important. Coming to management of specific conditions. Management of preeclampsia, judicious use of antihypertensive agents, and whenever delivery is going to happen less than 32 weeks, magnesium sulfate should be used for neuroprotection. Timely delivery is the key, balancing maternal and fetal infections risk. Antenatal corticosteroids are very, very important. They ensure a single course of antenatal corticosteroids, dexamethasone, is administered to all women between 24 to 34 weeks who are at imminent risk of preterm births. This is life-saving intervention for fetal lung maturation. Antenatal corticosteroid. Betamethasone should not be used. It is dexamethasone, and dexamethasone. Now, magnesium sulfate for neuroprotection. Here you administer to a woman which is less than 32 weeks with imminent preterm birth within 24 hours to reduce the risk of severity of cerebral palsy in the offspring. Now it has become universal practice among gynecologists. The dose is the same as we use it for eclampsia. Standardized antenatal care protocols are very, very important. We do give antenatal care, but the quality antenatal care is not there. It should be standardized antenatal care protocols, and our Prime Minister wants that every weekly in the first month and then once in a month it should be done by all gynecologists in public sector dispensaries. Develop and implement hospital-based protocols for premature births, assessment and management, ensuring uniformity of care across Bharat. One nation, one protocol. Systemic and policy level interventions are required, empowering mid-level providers, that is nurses, ANMs, to identify at-risk women for early referral, strengthening the referral system, establish clear, efficient pathways for transferring high-risk mothers in utero to centers with NICU facilities. These are all Government of India made protocols and everybody should know and follow them. Transport the womb and not the baby. I again repeat, आपको मदर को बेबी के साथ ट्रांसपोर्ट करना चाहिए और उसी फैसिलिटी में डिलीवरी होनी चाहिए जहां पर निकू की फैसिलिटी अवेलेबल है. Transport the womb and not the baby. Expanding access to sonography. Especially, this access should be made available for mid-trimester anomaly scan के साथ करना है cervical and screening. It should be made accessible and affordable, even Tier 2 and Tier 3 cities. Data-driven public health campaigns are very much required, as has been done in Kerala and South India, for birth spacing, which should be not less than 2 years. There should not be anybody who is malnourished, enters pregnancy, and anemia should not be there in pregnancy. Invest in follow-up. High-risk obstetric clinics, preterm follow-up clinics are very, very important to monitor these mothers and babies longitudinally, closing the loop of care. And this has done wonders. Even followed by ASHA worker has done wonders. And they have brought neonatal mortality rate to 1. Delhi has 4, but Kerala has 1. So in conclusion, the call for action is, colleagues, the battle against prematurity cannot be won in the NICU alone. It must be fought in our antenatal clinics, where our role is to be proactive and not reactive. The evidence is very, very clear. So the final 5S call for action is screen, universal cervical length screening. If cervix is less than 25 millimeter, you have to become proactive and give vaginal micronized progesterone. Supplement progesterone for at-risk women. Support and optimize nutrition, treat infections, aim 12-gram hemoglobin at delivery. Use antenatal corticosteroids and max self less than 32 weeks for neuroprotection. Systemize, that is, create robust protocol-driven care pathways. We must move from being just the diagnosticians of preterm labor to becoming architects of its prevention, as is done in developed worlds. Our concerted evidence-based action can ensure that every pregnancy reaches its full term and every baby gets the healthiest start to life. Thank you very much. It's a high time that the pediatricians skill themselves in the art of quality survival of preterm babies by using minimally invasive approach. And this presentation you will hear by budding neonatologist on the 19th of this month at 4 o'clock. Thank you very much.